Hi there, this is Charlie Clements, and I'm a first contact physiotherapist based in the United Kingdom. Today, myself and Brad, we're going to be talking about all things back pain, sciatica, particularly in athletes, and you're listening to the Physical Performance Podcast.
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to the Physical Performance Show, brought to you by Pogo Physio's online Telehealth Consultations and Hugh Darnell's online Strength and Conditioning. I'm Brad Beer, sports and exercise physiotherapist by trade and training and founder of Pogo Physio, and alongside my show co-host, Hugh Darnell, strength and conditioning coach and accredited exercise physiologist. Each week, we aim to bring you the latest and greatest information and inspiration designed to help you perform at your physical best. And of course, we do this across a range of different episodes, expert editions, featured performers, interest editions, and coaches' corners. And on today's episode, we're exploring a topic that everyone will typically deal with at some point in their life, whether that's their athletic life or their day-to-day life. And that is the topic of sciatica. Now, given that this is the Physical Performance Show, we're terming this athletic sciatica. And today's guest, Charlie Clements, is the perfect guest to wrap an understanding and a strategy around what the athlete stricken with sciatica can do. Charlie Clements is a first contact practitioner and specialist physiotherapist treating in the UK with a special and deep interest in the management of sciatica. Charlie has emerged in the last several years as one of the lead educators in this space for clinicians working in the field. Charlie runs Recognising Red Flag courses to help clinicians have the clinical ability to recognise serious pathologies in musculoskeletal care. You'll find Charlie over at The Thread Physio over on Instagram. And during today's conversation, Charlie explores the different types of leg pain that can occur, the drivers behind those. Charlie talks about the prognosis of what people might expect when they experience sciatic pain. Charlie gives some great strategies on how to best deal with symptoms and some top tips to practitioners in the field as well. There's a case study dropped in here, so get ready with your pen and paper for Charlie Clements, specialist musculoskeletal physiotherapist exploring athletic sciatica. Charlie Clements, this has been worth the wait. Thank you and welcome to the Physical Performance Show.
Hi Brad, yeah, thanks so much for having me on, and I guess good evening for you for coming into the clinic so late at night to accommodate for me. It's great to finally catch up, and thanks for having me on.
In the pursuit of knowledge, it's a worthwhile stay up late for, Charlie, to capture this. And I should give an early shout out to the good folk at Physio Network. The episode I listened to, I think, late last year, it was fantastic. And that's where I first heard about you, started to follow your work. And I thought at some stage it'd be wonderful to glean some insights from you around the management of sciatica per se in athletes. But before we go there, Charlie, you've been engaging in some running of late, I noticed on social media.
Trying to. I'm one of those people, I think, that sort of hit their third life crisis, and now I'm doing running and swimming and bits and bobs. So yeah, I've started to dabble in that for the last year and a half, 2 years or so. So I've got a marathon coming up again in a couple of weeks. And to be fair, training has been a little bit better for this time round. So I'm hoping for a 3:10 to 3:15 maybe.
Nice, because I think it was London, was that right? Your first marathon, was
Paris.
It London?
Paris,
that's right. So yes, and so this time you're going back for more.
Yeah. I haven't been put off just yet.
And Charlie, that's great. And we'll talk about maybe some examples in the running population of sciatica. But your clinical interest in all things spine-related leg pain. Where's that come from, and what's a day in your working life look like?
I don't really know where it's come from, in all honesty. I guess it's just more the sense of like I work in primary care, so general practice as a first contact physio. So for those who maybe aren't aware, it's kind of like it's a specialist role where you are responsible for the assessment and triage of people that come in to general practice, and rather than seeing like a doctor, a GP for their musculoskeletal condition in the UK, they'll see somebody like myself. And really, I guess it's a specialist assessment, advice, guidance, maybe a bit of rehab thrown in. Equally, the role I work in, I also have the responsibility of investigating and working that up if it needs to be referred to secondary care, for example, to, orthopedics, neurosurgery, that sort of thing. So I guess, we know that back pain is really, really prevalent. 80-90% of people will get it at some stage. And equally on top of that, I think it's something like 60% of people with back pain have some sort of leg symptoms as well. So you can appreciate, I guess for me, I see that sort of day in, day out quite often. So it was an area that I kind of wanted to upskill in pretty quickly. And then I guess I just sort of found a bit of an interest, and a few opportunities sort of came out in terms of teaching webinars and different projects, as you say, with Physio Network and a few other educational providers. And it's just kind of snowballed from there, really.
I mean, your Physio Network masterclass was brilliant, the modules. So if there's any clinicians listening, I'd highly encourage them to get across that. It's a fantastic resource. Charlie, just thinking about the prevalence of lower back pain, I'm 19 years into my clinical life. When people ask me, why has their back pain occurred? Maybe I'm taking the easy way out here. You feel free to critique my reply. My reply is life.
Yeah.
It's just happened because you got a pulse. Is there anything you'd add to that? Feel free to correct me.
No, I think, very often it's exactly the same. And a lot of the time when I see people, there isn't always like a mechanism that's brought it on. It's just something that people have like lived with for ages, or it's just randomly developed. And I guess, as you say, it is so common. I almost, sometimes an analogy I'll use in the right person is similar to like a cold. You might not know exactly what caused it. Instead, it could be a multitude of things. You might be stressed at work, you might not be getting enough sleep, you might not have done some exercise or been prioritizing and looking after yourself recently. And sometimes that can cause a cold, and equally it can sometimes cause an episode of low back pain. So for the right person, sometimes that can go down well. I've also done it on some patients, and maybe it's not been quite so well received.
I mean, the other cohort I think of is the athletes who mistakenly may believe that because of their fitness or their athletic prowess that they should be immune to back pain, lower back pain specifically. Anything you'd say to that cohort, Charlie?
Yeah, unfortunately not. I think, anybody can get it. And I guess, to be fair, particularly sort of like non-specific mechanical back pain, in theory, if you look after your general health, that is a positive factor that might mean that you're less likely to develop it, but it certainly doesn't make you immune to picking it up, unfortunately.
And then I think the other thing I observe from athletes is when they do develop it, their works mentality, which is typically athletically push harder here, get a result sooner or faster. It's often challenged by the realities of lower back pain and sciatica, where there's such a big time involvement and they can't cram an outcome.
Yeah, and I think you definitely will have worked with a lot more athletes than myself, so I can imagine that's quite a tricky demographic to treat.
But if I do this and I do that, can't I, won't it speed it up? And it's like, no, sometimes it won't. Often it won't. So let's explore this. Sciatica, it's an umbrella term. Most people, though, I guess, Charlie, on the street would resonate with what that means. But as a clinical educator, what does that mean to you?
It's essentially like pain that is traveling into the leg, and that will be due to some form of like nerve root involvement 9 times out of 10. So essentially something has irritated the nerves exiting the lower part of your back and that is likely to be the cause of the leg symptoms. Now, rarely you can get like an isolated sciatic nerve injury, so like in the actual pelvis and the buttock. So that might be due to like a mass or an endometrial like polyp, or possibly after like a hip replacement, something like weird and wonderful, but that's quite rare. The classic, I guess, is piriformis syndrome that people think of. Oh, I've got a tight piriformis, so that's pressing on my sciatic nerve, and that's why I'm getting my leg pain. I would say probably 9 times out of 10 that's not the case, and usually if somebody's coming into the clinic with buttock pain and symptoms radiating down into their calf, certainly the first thing I'm thinking of is this is coming from your lower back. This is coming from your spine. I quite like the term sciatica still. I use that with patients. I know from as you say, from a research, from a clinical perspective, we've started to sort of like disregard that as a term because it's not anatomically accurate. But I still use it with patients quite a lot because I don't think they need to get into the semantics of what somatic referred versus radicular versus radiculopathy is. If I'm being honest, that's probably more of like a clinical term.
So sciatica pain referring into the leg, in simple terms, 9 times out of 10 will likely be due to some irritation of the nerve or a nerve root in the lower back. What things can irritate the nerve roots? The
most common, particularly maybe in our like athletic population, is probably going to be your discs. So a disc bulge, a disc herniation, that could possibly be causing some mechanical pressure, so some compression on the nerve. We know also though that that's not always the case. So the disc itself is very inflammatory. So if you have an acute disc injury, that will initiate like an inflammatory response, the same as if you cut your leg or something like that, and we see redness and bruising and a scab developing, and it's thought that inflammation is something that can really irritate the nerve as well. Then I guess perhaps maybe in our sort of like older demographic, so maybe people as they get into I got to be careful here with ages that I say, but maybe sort of 60s and above, we're probably going to be seeing some other structural changes in the lumbar spine, so some arthritis for want of a better word, and that too can also potentially irritate the nerve as it's exiting the spine.
That's really clear, Charlie. Disc can often be discs, lumbar discs, lower back discs can often be a cause, as you say. Disc bulges, people will have heard of herniations and these sorts of terms, and then inflammation, from around that disc upset or irritation, which can irritate the exiting nerve roots. Something that I gleaned from your masterclass, Charlie, was that inflammatory nature of a disc injury and the effect that can have, and it made me think of a bee sting. I mean, I've been sort of, whether it's right or wrong, I've been describing disky back pain to patients ever since the masterclass is a little bit like, hey, this is like having a bee sting. What do you think happens when you get a bee sting? And patients have been like, well, it's red, it's swollen, it's sore as, and then it sort of fades away. Is that accurate, a bee sting?
I think that's quite a good analogy to use. And as you say, certainly it can hopefully help reassure people that with time, normally that inflammation will settle, and with that hopefully the nerve can calm down, as will the symptoms. Equally, even if there is a bit of like mechanical pressure from a disc, we know from studies and from literature that actually these can resorb and heal spontaneously on their own. So sometimes, again, I'll use that analogy of like a scab on your arm from a cut. And then naturally over time, your body will heal that and it will shrink and it will resorb. And the same can happen to the disc. And certainly, some people can get very worried about, oh, well, what if it's a really big disc injury? But from the studies as well, we've seen that things like the extrusions, so ones that are certainly much larger than a bulge, they tend to heal more favorably.
As in the bigger protrusions or bulges heal more favorably than the smaller ones?
Potentially, yeah. So certainly they can regress and resorb and heal better when they've done sort of like studies and followed that up. I can't pronounce the name, but there was some good work from Chi et al. In 2015 that looked at these and essentially found that the extrusions would heal and resort faster and better compared to something like the bulges. I guess the caveat with that is they're more likely to cause more significant symptoms, but certainly in clinic as well, I've seen cases and scenarios where people have had really big disc injuries, but then actually the symptoms tend to settle down quite favourably.
Yeah, I think I've definitely come across that over the years as well, and it's nice to see. It's just a matter of being able to implant that confidence and trust in the patient or the athlete that their journey is probably not going to be too dissimilar. You use the term immunogenic in the masterclass that you delivered, I think, from memory. What does that mean, immunogenic? These discs create an immunogenic effect or response? Yeah,
so I guess the disc itself is sort of encased by so the nucleus pulposus. So the inner sort of like water jelly-like content is encased by the annulus, which is kind of like a thick tire ring that sort of surrounds the disc. So it's a really strong, robust substance. But if that inner portion does bulge, protrude, extrude, however you want to sort of name it, because it's not been exposed to sort of like the body and its environment, it initiates that sort of immune reaction, and then you get that sort of inflammatory response where, like a bee sting, it's red, it's irritable, and that is thought to be sort of the main source and culprit of some of the nerve root symptoms that people experience.
Charlie, you used those clinical terms somatic radicular and radiculopathy before. Would you mind just outlining what they are for the clinicians listening in? So what do those terms mean?
Yeah, so I guess that's sort of come from some of like the researchers, the experts in sort of spine-related leg pain. And again, they've come up with these terms because they're considered more accurate than sciatica. And certainly I would agree. So somatic is a sort of pain that's coming from tissues, so somatic tissue, so that's stuff like your disc, the muscles, the joints, other connective tissue, soft tissue structures, and that can radiate into the leg as well. So again, another analogy I'll sometimes give to patients is the nerves in the leg will run up and join into the spine, where they share the same sort of house as some of the structures in the back, and that then gets relayed up to the brain. Your brain has a difficult time with trying to differentiate between the two, which is often why you get this referred pain that can go into the leg. And, you could say the same about headaches from neck pain, or, arm pain from a heart attack or something like that. So we know that referral patterns can happen with other types of conditions. So it's the same with the spine. And normally it has quite distinct characteristics compared to like sciatica or radicular pain. So usually people will describe that it's above the knee, and it's kind of like an achy, dull, gnawing type sensation, and they won't have any sort of, or they certainly shouldn't have like neurological symptoms, so they're less likely to have pins and needles or tingling or weakness in the leg compared to maybe some of the other subcategories. It can be similar to visceral pain, which is a bit of a sidetrack, but visceral pain, so coming from organs and things like that. With those, we would want to certainly be like considering past medical history, like systemic or constitutional symptoms as well, so like feeling feverish, sick, nauseous, stomach pain, those types of things, to differentiate between the two. Radicular pain is categorized as sort of like a gain in function, so that's where that nerve root is irritated, and that's causing sort of ectopic signals, is what's described in the literature. I sometimes say to patients, the nerve is pissed off. And that's what's causing such significant pain in your leg. And again, usually it's very characteristic. So it's burning, shooting, lancinating pain. It's usually below the knee. So often they'll describe some sort of symptoms in the calf or to the foot. And here you're more likely to see some kind of sensory disturbance as well. So tingling, numbness, pins and needles, that sort of thing. And then the final one is radiculopathy, which is an objective loss of function. So people will report things like numbness or weakness, and then that sort of correlates with a physical exam. So when you examine that patient, there might be some sensory change, left versus right. They might have an absent reflex, or they might have some weakness in their lower limb. It's quite rare for it to just be like a painless radiculopathy. If you've got somebody with that, you should maybe be considering other differentials as well. So like upper motor neuron causes. So certainly an example from yesterday, I had a guy, 78, chronic 9-month history of a painless foot drop. But again, we're kind of going off piste a bit here, but in terms of like treating that from a spinal perspective through surgery, it's now going to be very difficult for them to have like a complete resolution, because it's 9 months down the line, and this needs to ideally be operated within days, if not weeks. But certainly if somebody's coming in with a painless foot drop, that does kind of prick my ears up and get my attention to what else could be causing this. So is there something else neurologically going on that might be contributing to it?
Interesting case study. Somatic pain or symptoms coming from tissues, the share the same house concept as to how you can have symptoms elsewhere aside from the actual driver. And then radicular pain, which is a gain in function, ectopic signals, the nerves cheesed off or peeved off, or Charlie's version. And then radiculopathy, a loss of function where you'll see a sensory change or potentially some muscle weakness or some reflex changes, in simple terms, yeah?
Yeah.
But they're probably more clinical constructs than to the athlete, the patient out there with leg symptoms. They're not too bothered by the semantics, are they?
No, just what are we going to do to fix this, get it better?
You're listening to Charlie Clements on this expert edition of the Physical Performance Show. And if you missed our last episode 370, it featured Dr. Jen Hamer sharing around a key topic that affects athletic performance across all levels of participation, and that is that of body image and fueling. Jen passionately outlined some of the key findings from her recently completed PhD in this space, where she explored the risk factors for low energy availability in developing athletes. Here's a little snippet of my conversation with Dr. Jen Hamer.
A lot of the coaches were very receptive to the education, but we had one coach who could not understand why saying to a swimmer as she walks into a competition that you're looking super lean, you're going to swim really fast was a problem. And we kind of said, well, you don't know how that swimmer's got to that weight. It might have been through very unhealthy practices. But his argument was, yeah, but she looked really lean, and I know that if she's lean, she's going to swim fast. And we were like, well, how do you know that that's the variable that means she's going to swim fast? Couldn't it have been a performance variable? Couldn't it have been from her training? Couldn't it have been from any other thing that she's been doing? And we actually had some real coaches in the room that actually challenged him. So
be sure to jump back and enjoy and learn from Dr. Jen's sharings on episode 370. Whilst there, peruse the archives dating all the way back to episode 1, featuring surf lifesaving Ironman champion Ali Day. But for now, let's jump back with this week's expert edition, Athletic Sciatica with Charlie Clements. Charlie, imaging. What and when, where, and how might imaging come into play?
I think certainly, like in the role I work in now, it's exposed me to requesting imaging, to in some circumstances trying to interpret the imaging and then referring into secondary care. So I would like to think my understanding of it is certainly better than maybe a few years ago. I guess there is a lot of like nuance to it, but equally there are some like fairly black and white sort of constructs as to when or when you might not consider it. So I think certainly like early doors, if somebody's walking in, it's just pain that they're experiencing. There's no significant weakness. There's no red flags serious concern of like a sinister pathology, in that scenario, we don't need to be imaging straight away because it's not going to change the management. So certainly in the first, I would say 6 weeks at least, some might argue even longer, we want to be trying to sort of calm that down with physio, analgesia, other types of treatment strategies as well. So that's an example of when you wouldn't need to do it. Equally, I guess if you're thinking this is more of like a somatic referred type presentation, imaging probably isn't going to change the management for that, because I guess if we're looking to scan the back, we're looking at an MRI, which is going to give us a really good representation of the majority of the anatomy of the spine, as well as the cauda equina and the nerve roots. So if we're thinking actually their leg pain isn't from a nerve root pathology, then they're probably not going to be a candidate for a nerve root block or going on to have surgery for like a discectomy or something along those lines. So that's probably another example of when we wouldn't want to do it. For me, I guess there are a few times certainly where I would want to consider it. So concerns of serious pathology, absolutely you're going to be wanting to image that, and the urgency will obviously be very context dependent. Equally, if we've got somebody with concerning weakness or significant weakness, so if they've got weakness across multiple levels, or they, for example, again, have something like a foot drop, we want to be escalating that pretty quickly. So if somebody's coming in with an acute foot drop, certainly where I'm based in the UK, so Bristol, they go into accident and emergency, they go into A&E to get that examined, because time is essentially of the essence. The sooner you can get that diagnosed and treated, the better the outcome that person can have. So that's a scenario of where you would certainly want to consider your imaging. And I guess also for pain. So if you've got somebody with progressive pain or persistent pain, so I sometimes say sort of the 2 Ps, that is a scenario where getting something like an MRI scan could be useful here, because there are other treatment adjuncts that can be explored. So nerve root blocks, injections, or if that's not working, or if it's a more of a persistent case, potentially surgery, which we know does carry risks, but we also know they are effective treatments for helping pain for people that have sciatica.
I guess my takeaway there, Charlie, is that imaging, there's times when it may be appropriate, there's times when it is not necessarily appropriate. It's always context dependent and reliant on taking a good for the clinician to take a good history, perform a good exam, and have a good rapport with the patient to be able to talk through the options. But you mentioned there nerve root blocks or injections. I guess it's just a nice flow on from that comment, just to go there now. When may these be indicated? I know that's a general question, very broad question. And how do they work? And then what can patients expect?
It's a procedure that's often done by interventional radiology. So again, in the UK, we would refer these people to a hospital where they would be sort of treated by a specialist. Essentially, it's almost similar to an epidural, where the injection will go into the spine and then they inject, and that's under X-ray guidance, and then they will inject anaesthetic as well as corticosteroid. So it has sort of 2 effects. It can be diagnostic, because if you're on the money with where you think or what is causing the pain, we should expect some improvement, even if that's only for a few hours, minutes or hours, or possibly days. And then it also has the therapeutic effect, which is the steroid will then start to kick in a few days later, and that is designed to essentially reduce inflammation around that nerve. So it's a powerful anti-inflammatory, essentially. They tend to be better for your like early acute discs. So certainly sort of somebody that's had a disc bulge, disc herniation, these can be really quite effective, especially if they're done within a reasonable amount of time. I think there is a bit of uncertainty that if somebody's got more chronic or persistent symptoms, their efficacy, their effectiveness is maybe not quite so good. And equally, they can be effective for people if you've got a condition called stenosis, but involving sort of like the outside part, so not the canal. Instead, it's kind of the recess and the foramen, so sort of unilateral to one side, really. So sometimes that can be helpful if somebody's got pain in their leg because of that.
What's the gap between injection and maximum symptom change, if there's going to be symptom change, Charlie?
It's difficult. I think it varies, but in terms of it, normally I would say a couple of weeks. If they haven't seen any improvement within a couple of weeks, 2 to 4, let's say, ballpark figure, I think that you then start to sort of question, has that been effective or not? And then potentially you're kind of going back to the drawing board and reassessing and checking, actually, have I got the right diagnosis here? Or equally, there are scenarios sometimes where people don't get relief from it, and then they might need to be referred on to have something like surgery.
And are there any clinical criteria that you use as a clinician working with patients to consider proceeding to an injection, or is it more time course, symptoms, knowing your patient?
Yeah, it's tricky. I think certainly I wouldn't be considering it straight away. So I would want to have seen if there's been any improvement with different types of medication, exercises, physiotherapy, and equally a little bit of time. So people might agree or disagree with me, but I would say sort of 6 to 8 weeks for me in the NHS is probably a ballpark figure in terms of giving this time to settle down. And then if it's not helping, then that's where you have that sort of shared decision-making conversation about the benefits, about the potential risks. So, just off the top of my head, it's an invasive procedure. There is a chance that you could irritate or damage the nerve even more because you're sticking a needle in that sort of environment. Equally, people can get infections because it's invasive. People's leg can go numb for a day or two. People can faint. You can have allergic reactions. So it's not completely risk-free. So I think it's making the patient aware of that before they go in and have it done. Equally, I guess one of the biggest sort of precautions, contraindications, is if they're on blood thinners. So again, you need to let the clinician, the interventional radiologist, know about that, and then it's kind of a bit more of a medical workup and decision around, is this something that they could safely have whilst they're on this type of blood thinning medication. So that's kind of goes above and beyond my area of expertise.
I mean, you mentioned medication there a couple of times, and we both acknowledge that's a medical practitioner's domain, primarily. But how and when do you counsel patients through speaking to their medical practitioners around medication to help with sciatic symptoms? Definitely,
if pain is the predominant symptom that they're coming in with, which usually, as we know, is probably going to be the case as why they're seeing us. Early doors trying to get that under control is going to be really helpful here. For me, I sort of say to them, it's going to give you a window of opportunity, which is going to allow you to try and maintain as much of a normal life as you can. It doesn't even necessarily need to be exercising. Can we keep this patient at work? Can we keep this patient able to sort of, look after and care for their family and loved ones, or socialise with their friends? Because equally, we know if you're off work, if you're away from social setups and things you enjoy, they can be factors that affect the recovery, the natural history of this. So yeah, I think it's really important that they get some sort of experiment with medication, particularly early doors, to see if it offers them relief. Obviously, the doctor can go through them about the benefits and the risks, but some of them might be, with your anti-inflammatories, it's making sure people aren't on certain types of blood thinners. It can interact with blood pressure medications. People might have really poor liver or kidney function, heart conditions, those types of things, stomach ulcers, stomach bleeds. There's some of the risks and things you need to screen for.
With surgery, we'd be going back to some of the very earliest. It's probably between the 0 and 50 episodes. We did feature a neurosurgeon on the show way back then, Dr. Neil Cochrane, talking here in Australia about neurosurgery. I recall his comments being something along the lines of people would be surprised how few people ever need typically surgery for sciatic-related symptoms. What's your experience with that, Charlie? And when people say, "Well, I need surgery," like, how do you counsel them?
It can be really tricky, and I guess it's if you have time, certainly trying to explore like their thoughts and their ideas around why they feel like they need it. So often there is a reason as to why that's the case. So that might be because there's a big family history around spinal surgery, or their friend had this and it didn't get better, and they needed to have surgery. So it's trying to maybe explore that a little bit more and seeing if you can unpick the why as to why they think they need that. I guess we do have some good evidence and literature around the sort of recovery and the natural history. So the main trial I can think of is the Scopic trial in 2020, where they looked at people that had sciatica, and they compared basically like a usual care group to a stratified care group. So some of these people, they escalated their care, so they got really early physio or really early imaging or spinal injections or surgery, and they compared that to people who maybe just gave it some time, they had some education around the condition, and actually the results were fairly similar. So about sort of 75%, just under, got better, got significant relief at 1 year. Equally, I think around sort of 1 in 2 got significant relief at 3 months. So they are relatively favourable odds that this can recover, and it usually does get better. But I guess it's just counselling people that it often does take time. This isn't going to be the case of days, probably not even weeks. We probably are looking at a good few months. Equally, I guess it's stating to them about sort of safety netting and guidance around when to return and to come back to you as a clinician. So certainly for me, I'm saying, if there is progressive weakness, or your pain isn't settling down after a period of time, coming back and then reassessing, considering a scan, referrals on, those types of things is also really important.
Giving the patient that reassurance. There was a nice graphic that was in the Physio Network Masterclass, which I printed out in Having Clinic now. I'm looking at it right now, that you'd insert it into the class, and it's the graph that, in the heading of the slide, is often just give it time. 90% are thought to improve within 4 months. 50% were better at 12 weeks. 71 to 74% were better within 1 year, and one third continue to have symptoms in this paper. This is sourced from beyond 1 year. So there's some interesting statistics there.
Yeah, and I think certainly, again, the odds are favourable, and it's just being mindful that if it's not settling down and you've given it a period of time. So for me, I will normally say to people 8 to 12 weeks, then that's when to come back to me. And, potentially we then need to look at escalating this or investigating it a little bit further. Ultimately, sort of the decision is with the patient, really, with what they want to do. Yeah,
no, absolutely. Charlie, the neurodynamics, I'm doing a specialisation training program at the moment in Australia here, and definitely one of my facilitators isn't that sold on their effect or the concept, but certainly at an undergraduate level in Australia here, we were all shown the neurodynamic type of intervention as a treatment option. What are your thoughts and experiences on neurodynamics? And maybe just for the listener, could you just maybe give a bit of a description as to what they are?
Yeah, so I think they're sort of questionable in terms of how effective they can be. I don't think there's a huge amount of evidence that explores sort of how useful they are in terms of a treatment. To the best of my knowledge, I think I have read 1 or 2 studies that have suggested they can offer some improvement. So for people that aren't aware, it's essentially sort of a movement, a stretch, an exercise that is designed to place sort of tension and traction on the nerve. So usually that will involve some kind of like knee extension and movements at the foot and the ankle. And the theory behind that is that you're lengthening and shortening the nerve and its nerve roots. And in theory, that's designed to sort of reduce pain and potentially sort of promote healing and recovery. Certainly that's kind of my understanding of kind of how it is designed to work. Experience wise, I've had a few people that get on really well with it, and they seem to think that it can help quite significantly with their symptoms. And then I've equally had people where it's really sort of flared things up and they've not got on with it very well at all. I think probably picking your patient is important here. So certainly people with really quite high irritability and severity of pain, it's probably not going to be your go-to exercise straight away. But for some maybe that can tolerate it, it can potentially have some improvement physiologically and yeah, potentially psychologically as well. I don't know what your thoughts are on it, Brad.
Gosh, I remember graduating. It seemed to be all the rage here in Australia, but I have clinically used it very little really over the years. In more recent times, I guess you use the word irritability, and if they've got a low level of irritation, and I find I might clinically pop them in here or there, but yeah, I think it's picking your patient, like you've said a few times. I was just curious on your expert opinion and any literature around that.
I think there was a useful paper, I think Tom Jessen and like Anina Schmidt in like 2020. They definitely did one looking around like the physiology of neurodynamics and potentially sort of how effective they were. But I think, to the best of my knowledge from reading that quite a long time ago, there wasn't a huge amount of literature or evidence, and certainly they suggested that more needs to be done to sort of explore that as a treatment option. I guess the other thing is that any type of like movement of the body is gonna stretch and shorten that nerve as well. So even a graded walking program or a graded return to running, if you're something like an athlete and a runner, you're going to be stretching that sciatic nerve just by doing that. So I'm often a bit more of an advocate and a fan of just doing general movements and exercise and activity. Equally, if somebody's, a avid gym goer and they enjoy lifting weights and things, then it's about sort of maybe tweaking their program and regressing certain exercises and then trying to gradually, progressively overload them again whilst monitoring their symptoms.
I mean, is the theory that these neurodynamics are meant to oxygenate the sheath of the nerve, or is that just something that I've latched onto from somewhere? What's the proposed mechanism? As
you say, it's designed to sort of improve and boost circulation, which then obviously can help increase oxygen and maybe removal of waste products and things like that. But as we've said, kind of any type of exercise and activity is going to do that. Equally, any type of aerobic activity is anti-inflammatory in nature, and we know obviously with certainly in the younger demographic, the majority of these are due to a disc bulge, disc herniation. So in theory, that is something that could probably help with it.
Great movement. Before we went on air, Charlie, you mentioned that I think you had a recent case study of a runner with sciatica. Can you paint a little bit of a picture, and from this case example, share with the listener, perhaps the running audience who no doubt at some point have probably experienced sciatica, what some of your top tips are? Yeah,
so I think with, again, certainly in a younger group, we know that sometimes like coughing, sneezing, bending, sitting, so that sort of flexed posture can irritate the disc in some circumstances. But equally, I've certainly seen in scenarios and with this runner that kind of like the actual load, so being on your feet, putting pressure through the leg, can also be really, really irritable and provocative. Trying to get a runner to not run, as we know, is a hard task, and I can certainly say that I'm not the best patient as well, and I've got a few aches and pains and probably need a bit of a deload. But in this scenario, it's exploring other types of aerobic activity that they can do, so different types of cross training. This person could actually sit quite comfortably on a bike. So getting them doing some stationary bike, equally again, some cross training in the pool. So some swimming is another really effective way of just getting their whole body moving, and hopefully they're not really going to lose much aerobic cardiovascular fitness because they're still training that component. And as I say, coming back to the fact that we know the majority of these cases, inflammation is the main driver of symptoms. If you've got somebody doing lots of aerobic exercise and activity, it's going to produce natural pain relieving chemicals, and it's going to reduce inflammation and improve blood flow, which is in theory going to probably sort of speed this process up. As that started to get a little bit easier, you could then get them back doing some resistance training. So again, sort of trying to load the lower limb. So some examples of that might be initially doing something like a box squat, so reducing the height and range of motion that they need to work through, then maybe sort of loading them into kind of like a goblet squat or a sumo squat, so there's not quite so much of a hinge or sort of movement through the spine. And then as that slowly got easier, you can then maybe start to go to like staggered and more sort of single leg type work, so stationary split squats, step ups, lunging, those types of things. So I try not to get too bogged down in terms of like the biomechanics, but more in the sense of we're gradually exposing that nerve and retraining that system to tolerate the load a little bit better. I certainly am not a running physio as of yet, or a running coach, but I guess then in terms of getting them back to running, intervals, jogging, walking intervals, those types of things with rest periods, and then progressively trying to load that up as the weeks go on.
Brilliant. Some graduated exposure, progressive prescription of exercise work, and I guess you can't underestimate or understate the importance of reassurance as well. A cool head, a reassuring voice from the clinician working with the patient or the athlete. Absolutely.
Yeah, I completely agree.
I think thus far what you've shared there, Charlie, is very pragmatic and reassuring. It takes a bit of the mystique and the fear out of it, hopefully for people listening in who maybe have experienced it, or know someone perhaps going through it at the moment, or unfortunately most likely may and probably will experience it at some point in their life, right?
Yeah, to be fair, sciatica is maybe a little bit less common. It's really variable how much you see, but some say around about a third of people can get it. So I guess the odds are more in people's favour compared to picking up an episode of back pain. It's still very common.
Or a cold, as you said earlier there. I've had one episode of sciatica in my life. I'm 44, but it lasted for about 2 weeks, and I initially developed a bit of anxiety around it. It was a bit of a stressful period in life, and I had to take a step back and go, hold on, how would you coach your patients through this? Don't get too far ahead of yourself. And I was pleasantly and pleasingly surprised it passed within 2 weeks or so. But for one point there, I'm like, I'm going to be dealing with something else now. So, Charlie, let's play a game of threes. Yeah, this is a challenging game because there's so much you could share, as we've heard. But 3 top tips, Charlie, for the athlete experiencing sciatica. And I know this is not individualized advice, it's more general, but what would be your 3 top tips?
Definitely number 1, I think, is give it time. So be patient. Don't expect sort of really quick, fast responses, because often you might be left feeling a little bit disappointed. So that would be my first one. The second one would be try to keep active and moving, whether that's as we said, it might be temporarily you're not running, but you're doing some other type of exercise and activity. Something is better than nothing here. So I think you can go on Instagram, you can go on YouTube and find some cool, weird, wonderful exercises, but actually it's probably not going to outperform going for a walk or going and doing a little bit of stuff that you can manage at the gym or your Pilates class or your yoga class, but you've adapted it. So I think something over nothing and some type of movement is really, really helpful here. And then number 3, I think if in doubt and you are worried or concerned, that's when to consult seeing somebody. So, a qualified healthcare practitioner, somebody that hopefully has a decent level of understanding around the condition, who can, again, hopefully reassure, encourage them, and get you back moving and doing the things that you want to be doing.
Charlie's 3 top tips for the athlete with sciatica: 1, give it time, be patient. 2, keep active. Something's better than nothing. And number 3, if in doubt, consult with someone who's credible and qualified. And then along those lines, Charlie, the 3 top tips for clinicians listening in. Once again, it's broad advice. I appreciate that.
I think listen to my talk on Physio Network.
Absolutely.
Hopefully that is something that will help improve your knowledge and understanding of it. I think definitely in terms of being confident around giving it sort of a period to try and cool off as well for clinicians. So I think perhaps sometimes we can be guilty of over-treating people and trying to do too much, when actually time can be our biggest friend, is also important. And then 3 is maybe be willing and aware to get other members of the multidisciplinary team involved as and when you need. So doctors for medication, or referring on to other specialists or clinicians for imaging or other types of treatment techniques if things aren't settling down.
Charlie, every guest of the show, from episode 1 to you'll be episode 371, has issued a physical challenge to the listeners for the week. And this can be anything at all. You can make it easy, you can make it hard. What's Charlie's physical challenge going to be to the listener?
Physical challenge. Can I say my sort of challenge at the moment? So for me at the minute, it's swimming.
Yeah. All right.
So yeah, for me, trying to swim 200 meters, which is tough. I can do 100 meters at the moment. I can do 4 lengths of a 25 meter pool, and then I'm gassed. I can't go anymore. So that's maybe see if somebody can beat my 4 lengths, which I'm sure a lot of your listeners, particularly endurance athletes, could do in their sleep.
Well, there's a lady that I swim with here on the Gold Coast, and she just got back from completing the English Channel. So that was a mighty 12-hour effort for Jen. So but the English Channel, 200 meters, it's all relative, right, to the experience. She's a Com Games gold medalist. So take on Charlie's swimming challenge and maybe just swim further than you ever have before. Simple, right?
Nice. Yeah.
And Charlie, the other set question that every guest of the show has been thrown is, if you could boil everything you've learnt, in this case, you're an expert. This is an expert edition. If you could boil everything you've learned in your professional life down into one solitary piece of advice to help the listener perform at their physical best, what would that solitary piece of advice be, Charlie?
Treat the system rather than the symptoms. So kind of what I mean by that is prioritize your physical health, your mental well-being, your social relationships outside of other aspects of your life, because I guess kind of certainly for the clinicians listening, we know that they're kind of really big influencers in terms of injuries, illnesses, and equally like the recovery of those types of things. I think certainly again with internet, TikTok, Instagram, we see these like corrective exercises or like one-stop shops which can fix your pain, when in reality it's never that simple. And I think certainly working in primary care, working in the role that I do, the people I see that struggle the most with managing their injuries, their aches and pains, are the ones that haven't looked after their physical health, or potentially need more support with their mental health, or socially in terms of like job roles, that type of thing. Treat
the system and not just the symptom. I think that
sounds very philosophical.
That's very, very Charlie Clements. Charlie, that just prompted me just to hear from you briefly around some signs/symptoms of potential sinister pathology. So we're talking potential growths on the spine, metastases, etc. In my 19 years, I've knowingly encountered this less than half a dozen times, and sometimes with favourable outcomes, and other times young people, not pulling through with sinister pathology. So just to maybe as a quick sign off, just because it's such an important thing to not miss, what should capture practitioners and certainly patients and athletes' attention if they're getting, what things do they look for? I find in clinic people are often coming in quite worried about, they know someone that perhaps has had cancer and they've got nighttime pain and they're stressing.
Okay, yeah, I think that to reassure people, it's very rare, but equally it is something that is there and does crop up. And I guess certainly people are living much longer, and with that comes other health conditions which can increase the likelihood of some of these more worrying or nasty conditions. I mean, for cancer, there isn't really sort of like barn door symptoms as such. I guess the biggest risk factor is a previous history of cancer, and they're kind of your top 5 and your big 3. So what I mean by that is breast, lung and prostate are more likely to develop into bony metastases, in particular the spine, and then you've also got like renal and then thyroid or gastrointestinal as well. You're right as well, sometimes that can sometimes that can present as like nighttime pain. Trying to establish, is that positional or is it unremitting? So in the scenarios where I have unfortunately encountered people with malignancy, usually that's, they can't sleep, or they've had to sleep in a chair because they can't tolerate lying in bed or something along those lines. It's very different compared to if I roll over in bed, my back wakes me up, or I really struggle to drift off to sleep because my back's so uncomfortable, those types of things. And then equally again, weight loss, general feeling rubbish, really tired, fatigued, those types of things are some of the more systemic symptoms that could mean that you've got something else that might be causing it. But I guess, the big caveat is that this is often very rare, and equally you don't always need to have all of those things for it to be something perhaps a little bit more serious.
No, thanks, Charlie. I don't mean to finish that on an alarmist note. That's not the point, but I think it's worth mentioning that if something doesn't seem quite right, and you did touch on this before about consulting with someone, seek help. So thank you. Charlie, when I think of you, I think of a calm head for an unnerving problem, pun intended there. Thank you for being an easy to listen to, great teacher around this topic. It's not the sexiest of topics, but it's something that I think is very practical, and as we outlined, or you outlined, many people will experience in their life. So thank you for stopping by the Physical Performance Show and sharing some of your wisdom.
Yeah, thanks for having me on, and it was a pleasure, because I know obviously you've had some pretty big names on here, so I'm honoured.
Add Charlie Clements to the list. Thank you, Charlie.
Cheers, Brad. Take care.
So there you have it, another episode of the Physical Performance Show, and I trust and I know that you've enjoyed and learnt something from Charlie today. Don't forget you can find Charlie over on the socials, Instagram @TheThreadPhysio. We'll pop that in the show notes. You can also find the show over there @Physical Performance Show, and myself and show co-host Hugh Darnell with our names @Brad Beer, @Hugh Darnell, DARNELL. A big thanks to the team that make this show possible each episode. Daryl Misson, our longtime audio engineer, Susan Wilkins, show administration, Matthew Olding, show graphic design, and Keelan Hundley on our social and video editing. Now, coming up on the next episode of the Physical Performance Show, we keep this expert edition theme going, and we explore an often misunderstood space of athletic injury rehabilitation, and that is how to care for lateral ankle sprains. And this is something that most athletes will endure. However, 50% of athletes will go on to experience another ankle sprain injury, and up to 4 out of 10 athletes can go on to have ongoing problems due to just one solitary lateral ankle sprain. The effects of this can be quite profound in terms of performance and also lifestyle. So we seconded Dr. Jay Hurtle, an expert in this area, to explore the rehabilitation of lateral ankle sprains on next week's Expert Edition. So until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.